Hello, everybody, and welcome to another Helios speaker series. Just a brief overview for those who are not familiar with Helios. Helios aims to improve the care for hemoglobinopathy patients by bringing together experts in the field of hemoglobinopathies, and we provide training and networking opportunities. And so at the moment, we have over 200 members, and whilst the focus is mostly on Europe, we welcome members from all over the world. If you want to find out more, it's probably best for you to visit our website, which is heliosaction.eu. And our website, you also find an overview of the upcoming webinars. In the next few months, we won't have any webinars because of the summer break. But in case you missed any of our past webinars, you can also find the recordings there. Today, I'm very thrilled to welcome Professor Maddalena Casale. Professor Casale is an associate professor in pediatrics at the University of Vanvitelli in Naples. Her research focuses on pediatric hematology with a particular focus on hemoglobinopathies, including iron overload and thalassemia, endocrine and asplenia-related complications, and sickle cell disease. Professor Casale has co-authored national and international guidelines in thalassemia and sickle cell management, including the 2025 guidelines by the Thalassemia International Federation. She's also an active member in many professional societies, for example, the ERN Europe BloodNet or the American Society of Hematology. In 2019, she received the ASH Global Research Award. And today, Professor Casale will talk about her research on avascular necrosis, which is a common problem in sickle cell patients. Professor Casale, thank you so much for joining us today. It's a real pleasure to have you with us, and we very much look forward to your presentation.
Thank you. Good evening, everybody. I'm really glad to be here, and I'd like to thank the organizing committee and Stephanie Muth for the invitation and the interest in our work on avascular necrosis in sickle cell disease. Okay, the slides are coming up, yeah? This work, recently published in the British Journal of Hematology, comes from a pressing need to find a way for early identification of patients with avascular necrosis, to quantify the impact on daily activities, in short, to have a quantitative, measurable, and comparable parameter to evaluate and follow the evolution of osteonecrosis in sickle cell disease over time. And avascular necrosis is a highly prevalent complication in sickle cell disease, increasing with increasing age. Reported rates are of 3% at 10, 15 years and rise to 30% at 25 years, up to 50% after 30 years. Therefore, this is a very frequent and very early complication. Indeed, in the general population, disabling joint pathologies occur in late adulthood or in elderly, whereas in sickle cell disease, more than half of young adults develop this complication. And is it a mild disorder? It seems not. On the contrary, it's a progressively worsening complication. Let's look at this data, considering asymptomatic osteonecrosis detected just at radiological imaging due to a contralateral symptomatic osteonecrosis. Clinical progression defined as the onset of pain was reported in 91% of asymptomatic hips, and the more severe the radiological lesion at baseline, the more rapid the clinical progression and the onset of pain. And unfortunately, it's not even a mild clinical progression, because as many as 77% of patients had collapse of the femoral head. And again, the more severe the radiological lesion, the more rapid the collapse, which, however, was highly frequent, even in stage 0. And among patients with collapse, the 75% required surgery for intractable pain. And you know the burden of surgery in patients with sickle cell disease due to the pre-surgery preparation, the risk of anesthesia, and surgery itself. The onset of pain, the severity of baseline radiological stage, collapse in contralateral hip, and any other surgical procedure and pregnancy were reported as risk factors for clinical progression. The severity of the disease is an important factor in the onset of osteonecrosis in terms of number of vaso-occlusive crises, number of infections. Other studies reported also the number of acute chest syndrome. However, there is a point to be stressed to all specialists involved in the management of this complication, orthopedists, radiologists, physical therapists. The main risk factor for progression of osteonecrosis is sickle cell disease itself. Rates of progression reported for non-sickle-related avascular necrosis, such as due to alcohol abuse, steroid use, systemic lupus erythematosus, or idiopathic, are significantly lower, from 7 to 33% compared to over 91% reported in sickle cell disease. This is very important because specialists are often overwhelmed with the requests for consultations, but the risk of progression related to sickle cell disease should impose a priority on access to radiological and clinical evaluation. The main problem reported in all the various review and meta-analysis on the topic is the lack of a standardized assessment tools to evaluate the severity of this complication over time. Indeed, measures to assess joint function may impact many aspects of this complication: the early onset, the rapid progression, the lack of specific symptoms, as pain is the only symptoms of osteonecrosis, but it's the most frequent symptoms in sickle cell disease. Often pain due to osteonecrosis is intermittent, vague, not localized, and patients may not report it. The high rates of surgery with the need of outcome assessment, the extent of radiological lesions does not always correlate with clinical function or quality of life. All these aspects could be positively affected using specific and measurable tools. The first and sadly the only study which used a measurable assessment tool was published 20 years ago with the aim to assess hip function in sickle cell disease. The Children's Hospital Auckland Hip Evaluation Scale is an assessment tool exploring different domains: pain, function, limb, informal questions for patients, and a physical examination assessed by physical therapists, which needed to receive specific training in the use of this tool. In order to assess passive range of motion, manual muscle testing, hip flexion contracture, and this is the problem we experienced in our clinical practice using this tool. The need of a trained physical therapist is a barrier to the wide use and routine implementation of this tool in the most clinical centers. We used the Oxford Hip and Shoulder scores, which cover a variety of important domains, such as pain, motor ability, impact on daily life, with just 12 simple questions for patients. The form is online with automatic calculation of the results, or you can print the questionnaire and then use the online calculator, or simply calculate the score manually. There is a clear grading of the score, which indicates the severity of the complication based on the score value. And the availability of a validated score for the shoulders allows to investigate the function of the two mostly affected joints in sickle cell disease, and not only the hip. These scores are validated as joint-specific patient-reported outcome measures. They are validated in different languages: English, French, German, Italian, Dutch, Japanese, and they are appropriate for the use in patients with sickle cell disease around the world. The score underwent extensive assessment procedures to verify the reliability and validity in prospective studies, and they are used in court studies and audits. They are also used in national joint replacement registries, for example, in England, New Zealand, and Sweden. In addition, they have been used in surgical and non-surgical clinical settings for the assessment of different joint diseases, for example, osteoarthritis, osteonecrosis, in the context of arthroplasty, and even in general population to assess the hip and shoulder health. We needed a simple, cost-effective, and easy-to-use tool to regularly assess joint function in sickle cell disease, and for these reasons, this score seemed to be the most appropriate. Our first aim was to assess the joint function in patients with pre-existing diagnosis of avascular necrosis at any site, hip and/or shoulder. So among 357 patients with sickle cell disease, we selected 47 patients with hip and/or shoulder osteonecrosis. The hip was confirmed to be the most frequently involved site also in our patients, more than 70%, with 3 out of 4 patients having bilateral involvement. However, a not insignificant number of patients, more than 20%, have both shoulder and hip involvement, as reported by other authors. Median and mean age a diagnosis of avascular necrosis was 35 years, and the age of the last follow-up was around 45 years. Well, after 9 years since diagnosis also of osteonecrosis, the overall mean hip score was 28, meaning a moderate severe impairment, and the Oxford the score was around 35, meaning a moderate impairment. So both joint functions were abnormal. And assessing patients according to the genotypes, 3 out of 4 patients with avascular necrosis had S-beta thalassemia, half of whom had S-beta 0, while there was a similar prevalence between S-beta plus and SS. You know that the association with the alpha thalassemia trait and the genotype SC were reported as risk factors for osteonecrosis. So whether we didn't check the alpha genotype and no patients with SC genotype were included in this study due to the low prevalence of this genotype in Italy. However, what we can gather from this data is that genotype S-beta plus is not so mild as traditionally considered, and a significant number of patients affected by osteonecrosis was S-beta plus. No difference were observed in the general characteristic of patients according to the genotype. The only difference we observed was the higher rate of splenectomy in S-beta 0 patients in comparison to SS patients, and although not significant, S-beta 0 patients reported mean Oxford hip and shoulder score around 20 points lower than SS and S-beta plus patients, and we think this is a further evidence that splenectomy may represent a marker of disease severity. Among patients with hip avascular necrosis, pain was the only symptom reported, and 64% patients required surgery, with most requiring total hip arthroplasty at the age of 34. The Oxford score revealed a moderate impairment. And looking at data on progression of hip avascular necrosis, patients reported moderate to severe impairment irrespective of the type of treatment. 36% patients did not undergo surgical treatment, but the hip score was abnormal with mild moderate impairment. 64% patients performed the surgery, mostly the 82% a total hip arthroplasty immediately, and 18% performed conservative surgery at first, which failed in 3 out of 5 patients who then underwent total hip arthroplasty. However, the hip score revealed a moderate severe impairment in all patients but 2, outlined the need to improve the management of this sickle-related complication. And also the burden of shoulder osteonecrosis persisted after 9 years since diagnosis with moderate impairment. However, since the shoulder is not a weight-bearing joint like the hip, the need for surgery was significantly lower. However, patients were not free from pain and functional limitations. And assessing patients according to the site of osteonecrosis, no difference were observed between patients with isolated hip osteonecrosis, isolated shoulder osteonecrosis, and multiple osteonecrosis. Noteworthy data, in our opinion, is this. Although not statistically significant, probably due to the limited sample size, patients with isolated avascular necrosis of the shoulder had very low scores, both in the shoulder, which is understandable, but also and above all in the hip. These patients have been prescribed radiological imaging and are waiting for the results. And I come back again to the burden of this complication in the different groups of patients and showing that alcohol-associated osteonecrosis was defined more severe according to the lower Oxford hip score values. Well, I want to underline that our patients reported very similar scores and must also be included among the groups at high risk of more severe disease, and therefore they need priority for treatment. So avascular necrosis is such a frequent and significant complication in sickle cell disease. Its progression is so rapid and serious that it requires surgery in the most patients. We have no specific signs and symptoms, and the pain is often not associated with this complication, but the underlying disease. Therefore, routine monitoring of the onset, progression, and the surgery outcome is necessary. The Oxford scores seem to be appropriate for this purpose, considering the ease of use, calculation of the score, and its interpretation. These scores can also be used as outcome measures in clinical trials, as we are not able to properly assess the progression or the improvement of this complication, also considering the disconnection between the radiological lesions and subjective experiences. And I would like to end my presentation leaving as a take-home message the one reported by the authors of a commentary published in the journal regarding our work. Authors expressed the confidence and hope in using these patients-reported outcome measures to identify optimal treatment for this debilitating complication. So I really thank the colleagues who worked on this project and patients who had the most important role in this study. And thank you all for listening.
Thank you, Professor Casale. That was a fantastic presentation, really interesting on an issue that's, as you say, not often discussed. For anyone who would like to ask a question, if you could either raise your hand and then we unmute you, or if you would like to put your question in the chat, that's fine as well. I'm really curious to start off with, because you mentioned obviously that often avascular necrosis is picked up too late. So how do you think, how can the monitoring best look like, particularly for a non-specialist center? Because as you say, there are no guidelines available. So what are your thoughts on on the monitoring.
Yeah.
Is there like data on when avascular necrosis typically appears? Like obviously there is onset in young age, but when would be best to start the monitoring of these patients?
The problem, the issue is focused on that question. We really don't know the real burden of this complication because we don't have an easy tool to start monitoring. So it is reported that before 10 years of age, the prevalence of this complication is very low, around 30% is low, not very low because it's still higher than the general population, is lower, around 3%, and then progressively increase. If we have a easy to use tool, cost-effective tools to evaluate the joint functions and limitations experienced by patients, it should be really easier to identify early patients. So having the availability of this tool can early the diagnosis can anticipate the diagnosis that often is delayed because of no specific symptoms and signs.
That's very interesting. I have another question in a moment, but I give Petros a question first. He asked the question in the chat, great talk. Thank you. Maybe I missed it. Have you collected the PROM responses once or in multiple time points?
Yeah, no, in this paper, in this study, we collected just 1 point questionnaire, but we have collected also after 3 years. So we are proceeding with analysis of data because the survival of hip replacement is considered to be around 10 years. So we have just passed this 10 years of observation. So it would be really interesting to associate the survival of hip replacement to the scores.
Fantastic, thank you. Could I also ask again on the diagnosis of avascular necrosis, what would you say is the patient awareness about this complication? Because obviously one of the main symptoms is pain, but then pain is a symptom of sickle cell disease anyway, so it's difficult to say. And it might appear that they might just be obviously, you know, given some opioids and then obviously the avascular necrosis gets missed. So what's the patient awareness? Because if they're obviously aware, then they might be able to also discuss this with their healthcare practitioner better.
Yeah, yes, the problem is that maybe patients have pain or had pain in the last weeks or months. The pain then went out. So maybe often patients can report pain, but they cannot. And using the tools allows the focus on joint function. So for this reason, the diagnosis can be improved because it's a joint-specific questionnaire assessment. And so with an abnormal score, we can force the radiological imaging, X-ray or magnetic resonance, without the quantitative, a quantitative parameter. We can just rely on symptoms of patients, but when the symptoms is so localized and specific, often the lesion, the radiological, the bone lesion is in a really advanced stage.
Thank you, that's wonderful. We also got a question from Rosalia. Hello, would it be advisable to try less invasive methods as a precaution or first step before considering aggressive treatments?
Yeah, it is possible if we have an early diagnosis, because but even in other studies published, the need for surgery became necessary for intractable pain. So if we can diagnose patients early, we can start with not invasive or less invasive treatment, and just when the clinical function or the pain is intractable, we can proceed with totally arthroplasty. But the hope and the confidence is that the earlier the diagnosis, the less invasive and hopefully more effective treatment.
Well, Rosalia says, okay, thanks. We also have a question from Natasha Archer. Have you considered creating guidelines for diagnosis and management in children and adults? I think it would be very useful, especially in resource-limited settings.
Yeah, but also in high resource settings, this complication is really hard to for early diagnosis. So we really hope that this tool can help to improve the diagnosis and also to identify the outcome, the surgery outcome, or the different treatment outcome, because we don't have this indication. We don't have a parameter to assess the treatment and the optimal treatment. So we need to use this tool and to implement it in different settings. Patients underwent total arthroplasty, patients with conservative underwent conservative surgery. We need to improve our knowledge on the use of this simple tool, really simple tool for our patients, and we would like to give this useful tool to all patients.
Fantastic, thank you. We also have another question and comment from Petros Kontouris, who's saying, as part of this lecture series, we had an earlier talk that used another PROM instrument, AskQMe, focused on quality of life assessment. Is it possible to compare studies that use different PROM tools for the same or similar outcome, and how someone can choose the optimal PROM tools for each case?
If this is a good question, because if the tool and the questionnaire are easy to be filled by patients and clinical center, they can add not different, but more information. So the Oxford score is focused on different domains, and it was identified as for with a good a good with similar effect outcome for specific quality of life assessment or tools. So maybe we can use both questionnaire, both scores to gather more information. The important point is that these tools have to be easy to use, because patients are medicalized, so they often are overwhelmed of clinical assessment, instrumental assessment. So if the tools are easy to use, they can be implemented all.
Thank you very much. We also have a comment from Amino Idris Mohammed, who's saying, thank you very much for this great presentation.
Okay, thank you.
And then another comment from Natasha Archer, who's saying, my impression is that Oxford scores are very specific for hip or shoulder function, and AskQME is a general quality of life measure.
Yeah. Yeah, so they can be used both together. There are studies, the Oxford scores have been used in different clinical settings, and they, as I said, were the result, the scores were similar for specific quality of life tools and this course, but it would be great to use both.
Fantastic. Pedros Gonzalez also says many thanks. I'm quite curious because you said obviously access to radiology assessment is very difficult, possibly because of the cost associated with it. So do you have any health economics or anything from your experience to support a case that obviously if you diagnose it late, then the healthcare costs are exponentially higher than when you diagnose it early?
Yeah, this is a problem, because even in high research country, in different centers in this study, the issue related to performing advanced radiological assessment for patients who maybe require more assessments is a problem, as radiologists and consultants are overwhelmed from clinical consultations or radiological imaging. So if we outline the need for an early radiological assessment in patients with a quantitative, measurable parameter, maybe it could be easier, but we need to improve or widespread the use of this tool, because differently now we ask for we require prescribed radiological assessment for pain in patients who very often have pain. So it is a challenge, yeah, the access for radiological imaging.
And I'm also curious because obviously with the novel gene therapies for sickle cell disease, do you envision that the problem of avascular necrosis will also improve, given that sickle cell disease is one of the main risk factors?
That data on bone marrow transplantation and the impact of bone marrow transplantation on avascular necrosis are contradicting, because in some studies it has been reported an improvement. In other studies, this has not been. But the problem is, how do you identify, measure, assess the improvement or not? If you see just radiological imaging, it cannot be enough or enough for the time for the lesion. And so my impression reading that data on the impact, the contradicting data on the impact of bone marrow transplantation on avascular necrosis, my impression was that we don't know enough because we don't have a tool, a quantitative tool to really assess the improvement or the worsening.
That's very interesting. Thank you so much. Is there anyone else who would like to ask a question? Either maybe raise your hand or put the question on the chat. If people watch the recording and would like to get in touch with you afterwards, what is the best way to get in touch? Can they send you an email, Professor Casale, or is that okay?
Yes, of course.
Fantastic, yeah. Okay, so unless there are any more questions, so as I just mentioned, the recording of today's webinar will be made available in the next few days. So if you didn't get a chance to watch it today, you can watch it online then later. But Professor Casale, thank you so much for joining today. It was really, really interesting.
Thank you all. Thank you.
Your work is very important to make people more aware of this complication.
Thank you.
Yeah, we look forward to seeing more about your work and wish you a lovely summer.
Thank you.
Natasha Archer also says excellent presentation, lots of Pedro's as well. Thank you very much. Rosalia, excellent as well. So thanks you
all
from everyone for this fantastic presentation.
We could start to use at any center, any sickle center, and maybe share data and experiences because it's important.
Definitely. Thank you. All right, then, everyone. Thank you so much for joining today. Thank you, Professor Casale, for the fantastic presentation.
Thank you.
And you all have a lovely rest of the day then.
Bye-bye. Thank you.
Thank you very much. Bye-bye.
Bye.